Welcome everyone. We'll get started in a minute. We will just wait a few moments for all attendees to join. While we wait, we welcome Tracy Nowicki as our guest speaker today. We're thankful to have such a well-respected industry expert with us to talk about the subject of pressure injury prevention. My name is Richard, and along with my colleagues Joel and Selena, as well as the extended Novis team, we hope you enjoy today's webinar. Novis has a 20-year history in the development and sale of pressure injury prevention devices. We pride ourselves in offering ongoing training and education in the market. And with this in mind, we have invited Tracy Nowicki here to talk about the complex topic of pressure injury prevention. Tracy is a clinical nurse consultant in a major acute care teaching hospital in Brisbane. With both national and international experience in presenting on the topic of pressure injury prevention, she has established herself as a key opinion leader on the matter. As part of today's talk, Tracy will touch on the importance of support surfaces, and Joel and myself will present two short product highlights that Novis offers in this critical field. While we wait for everyone to join, please ensure you stay until the end of the webinar, where we will give instructions on how to receive your CPD certificate. We still have a few people filtering in. We'll get started in about 30 seconds. Thanks once again for joining us, and thank you to Tracy for your time and effort in putting together this presentation. I'll hand it over to you now, Tracy, and you can get us going.
Okay, I'm just going to share my screen. Okay, everybody can see those slides? All ready to go. So welcome everyone. Super excited to be here with you, and I really want to sincerely thank Novis for making today possible. I know that it's very challenging. It looks easy, but there's a lot of things to think about to pull this together. So I've got lots and lots to tell you today, and I've got a short amount of time to do that. So I'd like to cover how to do a skin inspection, and that sounds really easy, but there's quite a few things to think about with skin inspection and what's expected of us according to the standards, how to stage a pressure injury, and do an introduction to some considerations around support surfaces. So my first take-home message for you is that if you want to look after the whole person, you need to get the whole team involved. My message in this is that pressure injury prevention is not a nursing problem. It needs the whole team, going from your front-end staff, your carers, your AINs, right through to your executive leads, your finance people, your physios, your OTs, your dietitians, your diversional therapists, everybody. And don't forget the patient and their family are really critical to making all this work. Now, when we look at, if your portfolio is pressure injury prevention, then you need to be best friends with the person who's responsible for falls injury prevention, and also the person who's responsible for making sure that your patients, residents, clients get adequate nutrition. And then the other one is continence. So the person that's at risk of a pressure injury is also the same person who's at risk of a fall, malnutrition, and incontinence. And all these are risk factors that put together the risk of developing any of these injuries. So let's look at what the international standards tell us about comprehensive skin inspection. It actually asks us to do a comprehensive skin inspection. That does not mean as you walk down the corridor, you pick up the little pink nightie and you look and you go, wow, their bum looks pretty good today. That is not a comprehensive skin inspection. So what I'm going to do now is look at what is involved in a comprehensive skin inspection. And if we look at the latest guidelines, so this is the 2019 international guidelines. So this work is the culmination of the USA, the Europeans, and the Pan-Pacific. So in Australia, we're part of the Pan-Pacific. So it's Hong Kong, Singapore, China, New Zealand. There's about 9 that all make the Pan-Pacific up. And it's super exciting that we now together to try and work out guidance for you guys at an international level. So basically they cull all the information that's available and put it all in this simple book for you to read. And if you look at the section on conducting a skin inspection, it actually says, here's the 3 points. You need to do a skin inspection as soon as possible after admission or when you transfer the person. It needs to be part of your risk assessment, and you need to decide how often they need that skin inspection depending on their level of risk. And the really important thing that I think we're not good at doing is prior to discharge. So for those of you in aged care, it's really important that you do a skin inspection before they leave you when they go across to the hospital. You need to have evidence of what that person looked like with their skin when they left you and when they come back to you. So how do we do a comprehensive skin inspection and what's required? And I've put it in a simple methodology where it's not just looking at skin, it's actually listening and feeling. So what I'm going to go through is, what do I mean by that? What are you listening for and what are you feeling? And some of the considerations around skin inspection, you need to be feeling their skin temperature. What is the color of the skin? The skin is like the window of the body, and it tells you a whole lot of things that are going on inside a person by the color of their skin, the moisture of their skin, and the tuga of the skin. So by the word tuga, if you look at that picture on the bottom left-hand corner where they're pulling up the surface of the hand, depending on how that skin bounces back, it gives you an indication of the tuga, which tends to indicate how hydrated or dehydrated that person is and the condition of the skin. And the last one being the skin integrity, so the overall condition of the skin. Now, in the guidelines, when you see these 2 arrows up like that, that basically means, that's not like it'd be nice if you did it. The 2 arrows up mean you should be doing this. This is really important. And it tells us in the guidelines that we need to be able to differentiate between blanchable and non-blanchable erythema. So the term erythema means a persistent redness, like you can see on that heel. And so we need to decide, is that a persistent redness or is it a normal body reaction to pressure where you get that reddened area that dissipates? And so that's where we need to understand the term reactive hyperemia. So reactive hyperemia is the reaction when we take pressure off. The one word I want you to associate with reactive hyperemia is the word normal. It's the normal body response to pressure. So basically, all of you guys now, you're sitting down, you probably got your legs crossed while you're sitting down, and when you uncross your knees, you'll have this reddened mark like you can see in that photo. It looks very much like a stage 1. So we need to try and understand, how do we know it's a stage 1 or the normal body response to pressure, reactive hyperemia? And we tell this by its ability to blanch. So when we press on it, if it blanches, it means that the vascular system is still working. If it doesn't blanch and it stays red, it means it's a stage 1. So we now need to look, what else are we looking for? We need to look at differences in colours. Is there a big bruise? Is it black? Is it yellow? Is it blue? And is there a blue hue? I'm going to get onto what a blue hue means. We need to look at the skin. Is it dry? Dry skin breaks really easily. Overhydrated. That means that it could be contaminated by urine and feces or drool or perspiration, and this overhydrates the skin. When it overhydrates, it becomes very plump, and you add pressure and shear in there, and those little cells break very easily. Muscle wasting. Now, when we talk about linking pressure injuries and falls, the biggest risk of having a fall is this muscle wasting. Muscle is also a protective mechanism that helps us to move, and when we move, we don't get pressure injuries. It also protects our body by covering it. Muscles do a whole lot more, and I probably don't have time to go into that any further. And also looking at how medical equipment can cause harm to the skin. So when patients are sitting up, they can slide down the bed, their feet can be up against the hooks that hold the pressure relieving device on. It could be a cannula, a nasogastric tube. It could even be the side rails. It could be the cap of an injection that can cause problems to the skin. So we've discussed briefly what to look for. Now, what are you feeling for? And we're looking at, we're feeling the skin temperature. So in the guidelines, they say in 2.4, assess the temperature of the skin. Now, this is a 1 arrow up, so it means that we think you should be doing this. And it says that if the temperature of the skin is elevated by 1.5 degrees, it could indicate an infection or an inflammation. If the skin is cooler, it could mean that there's a poor blood supply. Warmer skin can indicate infection and inflammation, or it could also mean that there's a chronic vascular insufficiency. So you can see by feeling the skin, it's also telling you a lot about the body. And what are you listening for? Now, this person here, the person you're looking after, they've got a whole lot of things to tell you, and we need to listen to them. So when they say to you, gee, nurse, my heels are itchy, that is straight away an alarm for you, because itchy usually means that that's going to go from itch to sore. The same with the skin. You know, sometimes that they can have around the perineum can be itchy. That could be an indicator it's thrush. Lack of sensation can be an indicator of diabetes. Pain is our big indicator. And sometimes pressure injuries are so deep that they can be extremely painful, where a person can barely even want to live, or they can have no feeling if they're a diabetic. So that's telling you also a lot. Listen when they tell you they've had a history of a pressure injury. The biggest risk of developing a pressure injury is having had a pressure injury. When they tell you about their fragile skin, how they brush up against things and their skin breaks, easy bruising can tell you about the types of medications they're on. So listen to the patient. Now, a comprehensive skin inspection, as I said, it's not just lifting up the nightie and having a look at their backside. It's actually a head to toe anterior in the front and head to toe posterior in the back. It's looking under all those bony prominences, those skin folds, under medical devices is the really big one. There's a lot of information on now. And here's a photo here of someone, this is, for all I can see there, the only word I can see is neglect. Patients should not be rolled onto their garments and their tubing. This is something that is not about I'm too busy, I don't have enough staff. This is just total incompetence that harms the patient. And then I did mention to you about the colour. Now, I'm super excited about this because in the new guidelines, you know, up until now, we've only had graphics that show Caucasian skin. But now the new guidelines show Caucasian and darkly pigmented skin. And if you look at the top graphs there, you can see what healthy skin looks like. But then you look at the bottom graph, you can see what a stage 1 looks like. And it's very difficult to see a persistent redness on a darkly pigmented person. And when we're doing a skin inspection, we also need to understand that not everything is a pressure injury. So here you can see a fungal infection, and that drug rash looks awfully like a stage 1, but it is not. And here we can see incontinence-associated dermatitis. And again, for me to fully explain this, we would need another half an hour just to talk about incontinence-associated dermatitis. But in quick summary, the thing you need to see there is what is causing it, urine and feces, not pressure and shear. And you can see that edges, they're not distinct, whereas the edges of a pressure injury are very distinct. And here we have a skin rash, and you can see this is not localized, this is all over the body. And we've got a linear lesion, a skin tear, and a shearing wound. But the really important thing about when you're doing all that work around skin inspection is that you need to make sure that you have you've documented this. And this is the way, it's not just for legal reasons, it's not just for rules, it's about how you communicate with each other from shift to shift, because healthcare is complex and we need to be able to document what we see so we can see the progress of it. So that's a very brief summary on how to do a skin inspection. So now back to you, Novis.
Thank you, Tracy. Thank you very much for that. I'm just going to share my screen for a moment. Right. Thanks again, Tracy. Later in her presentation, Tracy will touch on the topic of support surfaces. In anticipation of this, I would like to quickly talk about STAR SL cushions. SL cushions feature a series of interconnected cells and are known for providing superior immersion and envelopment when compared with other cushion types. The Star range is simple yet comprehensive with 3 distinct cushion models. These cushions provide a high level of care with superior immersion, where you sink into the cushion, superior envelopment, where it wraps around and adapts to the body, and the subsequent benefit of pressure redistribution. In the range, we have the Standard Air, a single compartment cushion offering excellent immersion and envelopment for the majority of user requirements. We also have the Stable Air with the unique foam and cell technology, where contoured low-density foam cylinders are concealed inside the air cells to provide support and stability for a user. And lastly, we have the flagship Starlock cushion for unique customization requirements. Air cell cushions are not new to the market. However, Star cushions, and in particular the Starlock model, introduce some completely unique features that I would like to highlight today. Firstly, there is the 13 centimeter cell height. This allows for superior immersion and envelopment. As a rule, the higher the cells, the more the immersion and envelopment, the better the pressure redistribution qualities. Secondly, the Starlock function of the cushion offers the ability to lock the airflow between each and every individual cell. The functionality of controlling airflow allows you to create increased stability in the cushion. Lack of stability is inherent in the nature of most air cell cushions, often due to the air flowing from one cell to another. However, with the ability to lock the airflow between cells, you can set the cushion up, correct posture, and then lock off each and every individual cell to create the stability required by some users. Last but not least, the Starlock features the completely unique ability to create pressure-free zones in the cushion. By isolating a group of cells and locking them off, you can completely offload a problem area. The Starlock functionality essentially creates a completely customizable cushion. With the use of the handball pump, you can set and reset the cushion to meet a user's individual requirements, even as they change over time. For those of you that wish to learn a little more, we will provide you with a link to a recent webinar we did on Star cushions, which has a particular focus on the Starlock cushion. We have also developed a simple and easy to use automated prescription tool for the Star range, which makes it easier to select the right cushion for any seat size. That's it from me. Thank you for your time, and I'll now hand you back to Tracy.
Thanks, Richard. Back again with me. We didn't mention, I think there's about 400 of you on today, so that's super exciting. And I think I'm really excited about the fact that COVID hasn't stopped us. And it's really great that you guys have made the effort to come on to learn more about pressure injury prevention, and ultimately this makes sure that your patient, your resident client gets the best journey possible. So we've talked about how to do a skin inspection. Now we want to build on that, now that you understand some things to consider with the look, listen and feel technique. Now we're going to look at how to stage a pressure injury. So when we stage a pressure injury, you know, it's very interesting. It all sounds very simple, but what I know is that around about 30% of the pressure injuries that are being staged are staged incorrectly. And out of that 30% that are being staged incorrectly, about 60% of those are not even pressure injuries. So everyone's in such a mad panic about pressure injuries that they're calling every skin damage a pressure injury. And that's not good for you, and it's not good for the patient, because what it means is if you misdiagnose it, they're not going to get the right treatment. So I introduced to you very briefly the concept of understanding that, you know, a rash, which is all over the body, is not a pressure injury because it's not localized. I introduced to you the concept that incontinence-associated dermatitis can be distinguished from a pressure injury because its edges are all irregular, unlike a pressure injury, which has distinct edges. But I didn't say to you that incontinence-associated dermatitis can cohabitate with a pressure injury, so you can get the two together. So today I'm going to give you some other take-home points, and you probably need to go to the guidelines and read this again. So everything that I'm giving you comes directly from the guidelines. There's nothing I've made up. There's nothing I've summarized from journals. It's all in the guidelines. So the next take-home point I've got for you, and if I had a live audience here, I'd say to you, how many stages of pressure injuries are there? And everybody sits there. It doesn't matter which state I'm in or what country I'm in. They're all guessing. Oh, some say 4, some say 5, some say 6. I rarely ever get 7. And it's a trick question because, yes, we still have 4 stages, but we actually have 7 categories. Now, us nurses, we don't really care less what you call it. Just tell me what it is so I can go in and fix it. That's how we think. But on this occasion, I need you to understand the difference between a stage and a category. So I'll go into this and then we'll summarize it. So there are 4 stages. There are 2 temporary categories, which means they don't stay in that category. Eventually, they change and become a stage. And the one that sits on their own is the mucosal pressure injury. And I'm super, super excited about that. And I know Novis is down in New South Wales, but I do like to tell you that it was Queenslanders that really started embracing this in the first set of guidelines in 2009, with the first Pan-Pacific guidelines, when we actually documented that mucosal pressure injuries do exist. You cannot use the skin staging system to stage a mucosal pressure injury. They behave very differently to a skin pressure injury. And I'll go into that when I get to the mucosal pressure injury. So I'm just trying to get you a little bit excited, and hopefully you're all glued to the screen to try and understand the difference between the 4 stages, the 2 temporary categories, and the 1 mucosal pressure injury. So here we have it here. And again, as I mentioned earlier, we now have graphics to show you. You can see the Caucasian skin looks very different to the darkly pigmented skin, but this is only skin deep. Once you get into a stage 2 and that skin is broken, everything else is the same. So let's look at the definition of a pressure injury. And the one word I want you to take home from this is localized. When you're trying to work out, is it incontinence-associated dermatitis? Is it intrateginous dermatitis? Is it Marcy and Mari and all these sort of crazy terms that I don't have time to go into today? The thing you need to remember when you're looking for a pressure injury, it must be localized. And it's usually, not always, but it's usually over a bony prominence. And you have to think about what is causing it. And the cause is pressure, or pressure in combination with shear. Now, that's your next take-home message. The primary cause of a pressure injury is not pressure, but it is shear. So when the patient's sitting up and they're sliding down the bed, the little blood vessels and all the underlying tissue is getting crushed, broken, bent, and distorted. And it's this shear factor that is actually distorting the cells, reducing the blood supply, and causing it to die. Now, the new definition in the new guidelines say this can also be not just over a bony prominence, but in relation to a device or object. Stage 1. It's now the word for all pressure injuries is localized. The one word for stage 1 is intact. The skin has not broken yet. It is a non-blanchable redness. And it can be firm, it can be soft, it can be cold, and it can be hot. So remember I talked about the look, listen, and feel? That's where all that comes into. And you may not see this persistent redness in a darkly pigmented person. Now, I've kept the old graphics because I really like them. And this is the new graphics on the right-hand side. And they're both giving you the same message. So you can see it's usually over a bony prominence. The skin is intact. It's a persistent redness. So the word is localized, bony prominence, intact. That's a stage 1. And looks like this. It looks pretty harmless. But don't be deceived by how harmless they look, because they can be incredibly painful and incredibly dangerous. So the word I want you to write down there is painful and dangerous. Stage 2. Now, the skin is broken. It's partial thickness. Now, the really big thing to understand when you're trying to stage it is the stage 2, it doesn't have any slough. If it's shallow and it's got a little bit of slough, it automatically becomes a 3. But listen carefully, not all 3s have slough. Now, the next thing I want to go into is a stage 2 can be a blister. But the word I want you to hold in your head is it is a serum-filled blister, not a blood-filled blister. And I'll go back to that soon. The new definition goes on to say what it is not. A stage 2 is not skin tears. It is not a tape burn. It is not AAD. It is not maceration and excoriation. And here's the graphics here. So again, localized over a bony prominence. A stage 2, it is a shallow break, epidermis and dermis. It is not down to subcutaneous yet and looks like this. You see there's no slough and it's shallow, but the skin is broken. A stage 3 is now full thickness, and I call 3 for 3, epidermis, dermis, and subcutaneous. It may have slough, and you don't diagnose it as a 3 because it's not as deep as a stage 4, because the depth depends on its anatomical location. So if you get a stage 3 from a BiPAP machine, it's never going to be deep because you're straight over that bony prominence. Whereas on a buttock, there's lots of muscle and fat, so it can become deep very easily. And here we see, again, localized, a bony prominence, and it's 3 for 3, epidermis, dermis, subcutaneous. Now this one, it's shallow, but it's got slough, so it automatically becomes a 3. And what I like to say on here, I just want you to briefly think for a minute, just switch out of staging for a minute, think about prevention. What could you have done to stop this pressure injury between 2 knees? And all it would have taken was a patient wedge or a $6 pillow. And that's where I feel so frustrated. Now, stage 4, I call this all the way. Epidermis, dermis, subcutaneous, muscle, bone, tendon. And these, they don't have to be, it's not necessarily deep. It depends on the anatomical location. So pressure on the heel is a 4 very quickly because there's not a lot of protective muscle and fat there, and you're straight down to bone very quickly. So stage 4, I call that all the way. Epidermis, dermis, subcutaneous, muscle, bone, tendon, and these are incredibly dangerous. And this is, people die of these, people lose their limbs from these. So that's the message I want you to understand, that if we can understand how to do a skin inspection, early detection means early prevention. If we can stage it correctly, get the right treatment, we can save lives. And this is what they look like. They're terrible monsters. Now, that's the 4 stages. We're now going to go on to temporary categories. Now, this is a suspected deep tissue. You tell it by its colour. It's purple or maroon. This is classic of the little old lady who's had a fall. She's been on the kitchen floor for 3 days. And then she comes into hospital or, wherever she's been sent to, and you see this dark, nasty, it looks like a bruise. And some people call it a stage 1 because the skin is intact, but it's deep and dangerous. It does not matter what you do with this injury, it is going to progress. It will break down regardless of what you feed them, what you dress them with, and what preventative mattress you put them on. These are deep and dangerous. They can also present as a blood blister. So remember before I said to you, I want you to hold in your mind, the stage 2 is a serum-filled blister. With a suspected deep tissue, it is a blood-filled blister. So you really need to understand the difference between this. So these can appear innocent, but they conceal a deep and fatal lesion. And here's the blood-filled blister. And this is how people lose their legs. This is why it's so important that we understand how to offload heels. And there is a technique in offloading heels. It's not just about tucking a pillow under their legs. So that is the first of the temporary categories. The second one is the unstageable. Now, in the old days, we called all the unstageable stage 4s. But we really didn't know, was it a stage 4 or a stage 3, because it was covered in either slough or escher. So escher is that leather-like, you might call it a scab. It's this black, tan or brown, hard leather-like covering. You particularly see those over heels where you can't see past it. So until that Escher or slough comes off, so you can see how deep it is, you can't stage it. So that is why the suspected deep tissue, which progresses and deteriorates, or the unstageable until you can get the slough and Escher off, you can't stage either of them. But eventually you can stage them into most likely a 3 or a 4. So this is what the unstageable looks like. And it's super exciting now with the new guidelines. We've got these graphics that actually show. So you can see on that right-hand side, you can see half of it in slough and half of it in Escher. That's to show you what it might look like either way. It's unlikely you'll see a black and white one like that. It'll usually all be covered in slough or usually all be covered in Escher. And you can see by that photograph, you can't see how deep that is. We can assume it's deep, but you can't see that. You can't tell whether it's a 3 or a 4. So you have to wait until that Escher comes off. And here again, so generally podiatrists will tell you to keep the Escher on. It's like a biological dressing. But if it's on the body, they tend to tell you to take it off because it can cause infection. So there's 2 different methods depending on whether that Escher is on the body or the foot. Now, again, we've covered the 4 stages, the 2 temporary categories. Now we're going to cover the mucosal pressure injury. So a mucosal cavity is somewhere a moist lining inside the body. So inside the mouth, the rectum, vagina, on the end, the penis. That's the moist mucosal lining inside a cavity. Now, so you don't stage every mouth ulcer, these little white mouth ulcers we get, as a pressure injury, a mucosal pressure injury. The rules for a mucosal pressure injury is it must be device related. So these are very different as skin pressure injuries. You would rarely ever see exposed muscle. There is no bone prominent with these, they don't have bones inside them. And the other thing is, who's ever had a scab inside their mouth? The mouth doesn't epithelialize. So you might see, if you have an injury inside your mouth, this white tissue. And some people might misdiagnose that as slough and think you have to cut it out. When it is not slough, it's the healthy mucosal lining trying to heal, which is called coagulum. So that is why it's really important that you understand that the mucosal pressure injury cannot be staged with the skin pressure injuries, because the skin we go on, is it a stage 1, it's intact, is it stage 2, it's superficial, epidermis, dermis, stage 3, epidermis, dermis, subcutaneous, stage 4, epidermis, dermis, subcutaneous, muscle, bone, tendon. The mucosal pressure injury does not work like that. So that is why the staging system goes 4 + 2 + 1. They're all different. And here you can see, whilst it was Queensland and then eventually Australia that adopted the mucosal pressure injury, in the 2019 guidelines, for the first time ever, we now have a graphic to show what these look like. So now I'm just going to go into support surfaces. So we've looked at how to do a skin inspection so we can stage correctly. Now we're going to go into support surfaces so we can look at some methods to prevent pressure injuries or to try and stop them from progressing when someone's developed a pressure injury. So the first thing we need to do is look at, now I'm only because of time, only just touching the sides on this. There's we could speak for hours on all the different types of preventative strategies for pressure injuries. And remember, initially I talked to you about falls prevention, pressure injury prevention, malnutrition, and incontinence. So we know that if you are fecally incontinent, your risk of developing a pressure injury is 22 times higher. If you are fecally incontinent and immobile, your risk of a pressure injury is 37 times higher. So that's how important continence is. Malnutrition, and I love to tell you New South Wales people again, it's Queensland that did a study showing that if you are malnourished, your risk of a pressure injury is double. If you're severely malnourished, it's 5 times higher. So when we talk about prevention, there's all sorts of, I'm only narrowing this down for the sake of time. And this occasion, I'm going to talk about support surfaces. but we can't talk about prevention without talking about nutrition and continence management. And I do want to acknowledge the work that's been done in aged care, because you guys have been the leaders for a long time in how to manage continence. So now we're going to talk about what are you going to lie them on? And we all know the patient that you reposition them off their hip, and then you come back 5 minutes later and they've slid back onto their back. So I really like to use patient wedges and heel elevators. And then there's a lot of research now on preventative practice through prophylactic dressings. And this is not just a sticker on their bum. The dressing needs to be the 5-layered dressing, because that dressing is not just, it's not really reducing pressure, it might marginally do that, but it's also controlling heat and humidity. So it's got a microclimate control, and it also helps to reduce shear on the skin when I talked about that business of sitting up and sliding down. So there's a lot of research on dressings now, and some people don't like them because they peel off because of the forces of shear when they're sliding down the bed. But I always say, isn't it good that the dressing's being sheared off and not the skin? Because once that skin's broken, it's very difficult when you've got a person who can't breathe and they're having to sit up to breathe. You can't say to them, well, you can't sit up anymore, you've got to lie on your side, because that's not going to happen if they can't breathe. But once you've got that broken skin, very hard to heal. And we can't underestimate the value of seating. So we know that when a person's sitting up, 70% of their weight is on their coccyx, and the coccyx is the highest pressure injury risk site. So seating is really important. So having leg adjustable chairs to get the safe transfer right so we can reduce falls. It's really important to have armrest on chairs, because that is actually helping the thoracic cavity to expand. So the breathing is really important, because when we breathe well, oxygen helps to make collagen, and collagen is the spider's web in the wound to help for wound healing. So can you see I'm giving you this massive puzzle, and there's all these little pieces everywhere that all start to fit together really well. And it's how we position them when we're sitting and how long we leave them sitting out. And then in the middle here, we've got a bariatric chair. So we often cause pressure injuries by trying to squeeze these large patients into standard sized chairs. So, and then you can see the cushion, the star cushion that you just had some talk from Richard on. And there's a lot of evidence behind the use of appropriate seating. And then that funny little cushion on the right-hand side is, we've done a lot of research on occipital pressure injuries. And they're really tricky little things, because you won't see an occipital pressure injury because of the hair over the back of the head. That's the occiput there. And when we saw this as a big problem when H1N1 swine flu came in 2009, and we had this large population of 19 to 49-year-olds dying of the flu, and they were on this life support with lying flat on their back. And a lot of those young girls that survived that near-death experience came out complaining about the bald spot on the back of their head. So where possible, before this person becomes hemodynamically unstable, we try and put a preventative device behind their head. And this is where, when I talked about look, listen, and feel, you won't be able to see anything, but you will be able to feel where the back of the head becomes very boggy. And often people don't recognize these occipital pressure injuries until the wound is breaking down and the exudate tangles the hair, and then the hair becomes matted, and that pinpointed mat creates that pressure injury. So this is a $5 piece of foam that's been segmented, and the whole idea of segmenting the foam is along the lines of what Richard was talking about before, where you try and immerse into the cushion. So let's have a look at what the guidelines say to us about support surfaces. Now, this is a little bit complicated, so I need you to be patient with me and try and understand what I'm saying here. So just to keep it simple, I'll stick with the one on the right. So there's two different types. There's reactive and there's active. So reactive means that the surface changes when there's a load on it. Active is only ever powered, and it alternates, one up, one down, or two up, one down, or 3 up, 1 down. That's another talk for another day. I think Novis can talk to you about 1 cell versus 2 cell versus 3 cell versus 4 cell alternating technology. But what, in summary here, you plug it in and the cells will alternate regardless of if there's any load. And the purpose of it alternating is it's mimicking you healthy people that you all move about every 11.6 minutes through the night. And so the job of the support surface is to mimic that moving, to take pressure and unload pressure, to take pressure and unload pressure. And this allows the body to react by reactive hyperemia. You remember reactive hyperemia? The word normal. This is how, when we offload pressure, and you might be sitting there now thinking, I can't wait till she shuts up. And then you stand up and you get this big flush of red onto your backside, and that's normal body response to pressure. It goes and blanches. It means you're all healthy. That's all good. Now, the reactive side, it can be powered or non-powered. So the easiest way to think about non-powered is foams. There's foams, gels, air, or a combination. In summary, I'm not a big fan of gel. I think gel is heavy, it's hot, it's cold, and it's expensive. You saw examples of air when you saw what Richard showed you with the cushion, inflating air, allowing immersion. And I'll show you some examples of foam and the things that we do to it. Now, the powered low air loss. So low air loss means it flushes a whole lot of air through the air cells of the mattress. And its theory is that it actually cools the skin and tries to create a microclimate. They can be very noisy and they can have weight limits. They can, a lot of them only take like 135 to 165. So reactive can either be powered or non-powered, and it changes depending on when it's loaded. Active is only ever powered, and it alternates without any load being applied to it. So let's have a look here. So I'm just repeating myself so you can try and think about it for a little while. You see reactive on the left, it's spreading load. So if you've got 70 kilos, an example I use, if I get this finger on this table, that little pinpointed pressure on a hard surface hurts. If I get my hand and thump it on the table, it doesn't hurt as much because I'm spreading the load by increasing the surface area. That's how reactive surfaces work. Alternating therapy works by offloading and allowing reactive hyperemia to come in. Get that blood in, food in, oxygen in, waste out. So you get lots of high pressure and then no pressure. Lots of high pressure and no pressure, mimicking what you do all night. So in summary, I want you to start thinking about pressure injuries at a microcellular level, not at the skin level. This is where it's all happening, and this is what we need to think about. When the person is sitting up and they're sliding down the bed, it's these little blood vessels that get crushed, broken, bent, and distorted. If they don't get blood flow through them, you don't get food, you don't get oxygen, you don't get waste getting taken out, and the tissue dies, and that's how you get a pressure injury. So we need to think about, well, how much pressure is that to cause that? And if you look at this glass here and these white fingertips, it's an empty glass, and that's all the pressure it took to occlude those blood vessels. So what we're trying to achieve is keeping those blood vessels open by offloading the pressure. When we don't, oxygen drops, carbon dioxide goes up, and the body responds with reactive hyperemia, flushing blood in. That is normal, but you remember you need to understand the difference between reactive hyperemia and a stage 1. Now this slide here is just showing that you don't get rid of pressure, you just change where it is. So here in this slide, green is good, red is bad. So when we turn them on their side, we're not reducing pressure, we're just moving the pressure to one area. And here, this is looking at some heels through a glass coffee table. You can see there is absolutely no blood supply getting through there at all. And that is how pressure injuries develop very quickly, where that tissue will die. And depending on their comorbidities, diabetes, vascular insufficiency, poor condition of skin, how quickly that will break down, But what you need to remember is these things damage within it. Here is the I said about the edges being distinct. You can see on the bony prominence where there's been no blood in, no food in, no oxygen out, and the tissue dies. And that's what happens when we don't offload. So that's looking at powered surfaces. Let's look at non-powered, reactive. And you can see here where these heels are sinking into this foam and it's spreading the load. So that bony little pointed, bony prominence of the heel, instead of it being on a hard surface like the old days of vinyls, it's sinking in and reducing the amount of pressure. Now, these mattresses are quite complicated. You can see on the right-hand side there, there's different layers which all have different jobs to do. But this is what your job is to immerse the patient into the surface. So if you look at the old days, we had tight white sheets that we used to knot in so they were really tight. That is all over Red Rover. Those days are bad. We want the person lying in the mattress, not on the mattress. And if you have a look here, this is an example of one of Novis's foams. You can see they're quite complicated. There's special foam for the sides. There's a special cover on the bottom, which is very different to the cover on the top. There's your comfort layer, your pressure reducing layer, and the layer that takes the weight. It's quite a formula to get these base mattresses right. When we look at the active powered surfaces, the cell is very eggshell-like, so that when you've got someone lying on it, you've got as least as possible touching the cell, and then when it deflates, you get that gap, allowing reactive hyperemia. One of the points that I want you to remember is that the surface cover has a 50% ability to reduce pressure. So if you back up the bed with plastic mats, pinkies, blueies, even continence pads, they all dysfunction the surface. Now, I'm not saying don't use continence pads, but the more things you put between the mattress surface and the patient's skin, the more this device can't do its job. So here is showing you, see how the cells are very eggshell shaped? And then you can see when one goes down, it's quite big. It allows that blood flow to come in, and then the other one takes the load of the weight. And this same theory applies to seating. This is here where it's immersing the bony prominence over a greater surface area. And I think wedges, I really like the use of wedges rather than pillows. Patients are very good at pulling pillows out. I like using wedges because they tell a story. It means that this person needs offloading. And it's really important we understand how to offload heels by supporting from the back of the knee through to the Achilles, the whole leg, otherwise you will cause DVTs. But the guidelines tell us you must do a 5 to 15 degree knee bend, otherwise the kneecap will obstruct the big blood vessel running down your leg, the popliteal artery, and stop the blood flow to the heels. So, in summary, you can see that a pressure injury is a localized area of damage. What I can see in this slide here is you can see there is a sheepskin. Remember that I said that whatever you put between the patient's skin and the surface, you are dysfunctioning the surface. Obviously, this guy is malnourished. He's a falls risk, he's a pressure injury risk, and he's got a continence pad, a Kylie on, all those things are all dysfunctioning the ability of this device to do its job. What I can see is he has beautiful skin, and yet he's been left lying in one position for too long without me going into any lessons on anatomy and physiology. You can see where the head of his trochanter, his hip bone is. You can see where it was pressing up against the mattress for a period of time. There was no food getting in. There was no oxygen getting in. There was no waste getting out, and the tissue has died. And I believe this man would have died of probably an osteomyelitis. You can see how red that is. This pressure injury would have been what killed him. So in all the things we talked about, understanding risk factors, continence, malnutrition, falls and pressure injuries, understanding how to do a skin inspection, look, listen, and feel, and understanding how to stage a pressure injury. There are 4 stages, 2 temporary categories and 1 mucosal pressure injury. I think we covered a lot of ground in 45 minutes. I hope that's helped you to understand the importance of understanding how to do a skin inspection, stage a pressure injury, and some advice around some support surfaces. But there's a whole lot more to this story. But thank you very much for listening.
Thank you, Tracy. I will just take over now. I know there was a few questions raised during Tracy's talk. I can assure everyone we will get to those questions. We'll be sending out a survey following this webinar. So just keep an eye on your inbox and reply with any question you have, and we will respond. So firstly, on behalf of Novis Healthcare and all our attendees, want to extend our deepest appreciation for your time and invaluable knowledge around pressure injury prevention. It has been an absolute honor to have you speak on our behalf here today, and thank you for your ongoing work as an industry leader in this space. And finally, I would just like to share a brief product showcase around our flagship alternating pressure mattress, the ProCare Plus. So here at Novis, pressure care, it's in our DNA, and it's something we are passionate about, much like Tracy. In my role as a product manager, I'm able to focus on the technology, materials, and design to bring these products to life, and really focus on demands of the Australian market, whether that is the needs of our dealers, OTs, end users, aged care and hospital staff, or residents. We really pride ourselves on the contribution we are able to make alongside those identifying individual risks and stages of pressure injuries in the field. And the ProCare Plus is a perfect representation of our goal to develop the tools to assist in the work that we all do. It's an innovative and technologically advanced product with a host of features and more importantly, benefits, a few of which I'll highlight with you today. We do offer detailed tech training, education outreach, and other channels to dive into these in greater details. So I invite you to join us at a later stage and really understand some of the thought and consideration that has gone into these products. So Tracy mentioned in a brief explanation, what is an alternating pressure mattress? At its core, it's an artificial and automated support surface that mimics the natural and spontaneous movement of the body to promote that circulation. But what makes the ProCare Plus special is the details of design that make it smarter, more flexible, and safer than many of the options you may have come across. So today I'm going to discuss 4 features, in particular, the ease of auto care, the utility of heel care, the safety of fail-safe, and the intelligence of the auto fouler. With auto care, you often hear the term set and forget, but this can be a bad thing. For example, if the user weight was set initially and the therapeutic benefits were diminished or even negated ongoing, with ProCare Plus auto care, you simply can't make the same mistakes. And the intelligently designed algorithm adjusts in real time, regardless of whether the individual has been repositioned or an existing system is set up for a new person in a facility, for example. You can still make adjustments to the pressure level based on comfort, but it remains in a safe range no matter what. This means new staff or a family that may be operating the system require far less setup training, and human error is virtually eliminated with regard to pressure setting. Another great feature unique to Novis is the disconnectable heel cells. And as many of you can attest to, the bony prominences of the heel are extremely susceptible to pressure injury. And with some creative valve design, we were able to deflate and lock out specific cells below the heels to allow for complete offloading in these areas. And while allowing regular alternation of the remaining cells. So in a sense, we've engineered another valuable pressure injury tool akin to a heel lift suspension boot into the mattress that can be activated at any time should the need arise. Next is the backup battery, which is a simple enough concept, but offers peace of mind for those in areas prone to power outages. The battery comes standard in the ProCare ProCare Plus, and it's a long 5 hours of dynamic alternation that kicks in automatically and offers a critical safety net for those most at risk, as well as provides active therapy during transfers between facilities, for example. And finally, the automatic Fowler boost. This clever feature addresses the increased shear and pressure Tracy talked about that occurs when individuals are seated upright on an alternating pressure mattress for any period of time. User's weight is more focused on the coccyx and sacral region, and when they're seated, this creates a higher risk of pressure injuries in these areas. With the ProCare Plus, it has a tilt sensor embedded in the mattress that instantly adds more air to the cells to prevent bottoming out in this position. The cells are triggered to inflate temporarily while the back of the bed is raised, and it allows for more support and to protect the user from the increased focused weight. Again, this clever design is automatic, and it limits the need for the carer to attend to this risk. It also reverts back to the previous pressure when the bed is laid flat. And that concludes our webinar. Thank you again, Tracy, and all of our attendees. Keep an eye on your inbox for a follow-up survey and any future events you may wish to attend. Appreciate it. Thank you.